The following podcast is part of a certified educational activity titled Eye on Equity, a comprehensive approach to DR or DME care in underrepresented populations. Access the entire activity and complete the post-test at peerview.com/SYS860. Downloadable slides and practice aids are also available.
Hello, my name is Joseph Coney. I am a vitreoretina surgeon at Retina Associates of Cleveland in Cleveland, Ohio. Today, we're going to focus on a comprehensive approach to diabetic retinopathy and diabetic macular edema care in the underserved populations, and we'll be keeping an eye on equity as we go through this discussion. Now, the main goals today is to equip you to address the unmet needs and barriers to the treatment of diabetic eye disease among people of color and in underserved populations. We'll try to prepare you to integrate the latest clinical and real-world evidence into treatment plans for patients with DME and also provide guidance on best strategies to facilitate adherence to recommended DME treatment protocols. Today's discussion is going to discuss how we can improve diabetic eye care in a multidisciplinary approach across all patients' demographics and talk about some of those barriers that may prevent us from delivering the best quality of care. The reason why we're here today is because we know that the prevalence of diabetes in the United States continues to rise. And this is just not a problem in the United States, it's a problem worldwide. But closer to home, we know that diabetes continues to increase. And unfortunately, it affects certain populations more than others. For example, Blacks, Hispanics, and Pacific Islanders are more affected than whites. In 2030, we expect the prevalence of diabetes in the United States to increase from 39.7 million to 60.6 million in 2060. In the United States, we typically see our Black and Hispanic patients living in our bordering states, either the southeastern or the southwestern part of the country. And so depending on where you practice medicine, your clinics may look different. If you live in these areas, you may see a higher proportion of individuals and therefore may see a higher prevalence of retinopathy in those individuals that have diabetes. Diabetes is so complicated that it affects so many problems. We know that it has a higher incidence of strokes, coronary artery disease. It has the leading cause of individuals that may have amputations and end up needing dialysis. And closer to home, it is the leading cause of blindness. It affects 30% of individuals with diabetes. Half of those individuals would develop diabetic macular edema, and that is the leading cause of decrease in vision in the working population. Now, when it comes to healthcare utilization, those individuals that have diabetic macular edema, they have much more significant comorbid conditions than those individuals that does not have DME. In a review over a 3-year follow-up, they found that individuals that had diabetic macular edema had a higher incidence of myocardial infarctions, strokes, congestive heart failure, peripheral vascular disease, lower limb amputations, and by far the most common thing we saw was renal disease. Racial and ethnic disparities in diabetes is definitely seen. We know that Blacks, Hispanics, and Native Americans have a higher risk and prevalence of diabetes. And unfortunately, on time of presentation, they normally present with more severe disease. And this is really unfortunate because we know that timely diagnosis and appropriate therapy often leads to the prevention of further vision loss. We understand why this happens. We understand that there may be a demographic or a non-demographic and even social factors that creates these health disparities. We know that particularly if individuals are socioeconomic deprived, may not have a high school education, these individuals are most affected because they delay therapy. They may not be able to afford or may not even know how diabetes affects their lives, and therefore they come in with much more advanced diseases. We now understand that these pockets that cause this are termed as social determinants, and these social determinants are many ways which affects the mortality and morbidity of how different medical problems will affect their lives. We know that just by being a Black or Hispanic or having lower education and lack of insurance, there is a higher association with visual impairment with these individuals. Now, this may differ for everyone, and I know that we may not have control over all the social determinants of health, but I think at the end of the day, the most important thing that we can provide as healthcare providers is good quality of care, making sure that patients understand the importance of their disease, decreasing the anxiety, the mistrust, the distrust, the things that we can provide to understand the patient's journey to provide the care that they need. Health coverage, we know, is the issue in this country. I think it's really important for us to continue to make sure we talk to our legislators to make sure that we can do the things that we can for our patients. The things that we can't control are the social determinants of health, but we can mitigate that by just providing best practices, dealing with our own implicit and explicit biases to make sure that they feel that the things they need are important. Sometimes health literacy is important. They may not even be aware that diabetes affects the eye. So therefore, they may have even been seeing a physician over the past 15, 20 years, and they're just now coming to see you for the first time. And it's really important that you explain to them that once a person is diagnosed with diabetes, they need to be seen. This is critical because there will be other members in the family that may have diabetes. They may want to get those patients in to be seen before they have vision loss. We understand that if they live so far from the clinic, it's difficult. It's very difficult once you live more than 40 minutes from a clinic to make sure you keep those appointments. It's very difficult if you don't have a safe place to work out or walk. I think geographic areas or zip codes or where patients live is probably the biggest factor on disparities. And I don't think this is a black or a white thing. I think that anyone in those areas, they all have the same problems. They all have the same type of education. They all have this very similar insurances. They all may be faced with food and scarcities. And so these individuals may have a higher burden of coming in and keeping those appointments. But once some of these are addressed, I really think that we can really change or increase or decrease the mortality, the morbidity rates that come with this to increase a life expectancy for all people. Now, in the 2016 National Health Interview Survey, they looked at the association of social determinants of health and self-reported visual difficulty. And what they found is that non-white race with a lower education and lower income and having no insurance or being uninsured had a higher rate of reporting of visual impairment. The disparities in self-reports in difficulty in seeing in the United States were more commonly reported if they were unemployed, if they had an education level that was less than a high school diploma, if they were from a poor area, if they were underinsured or no insured. All these individuals reported difficulty, a higher rate of difficulty in seeing. And so we know that minority race and lower income are associated with higher rates of visual impairment. But I really think that this is much more complex than what we see from the patient. I think there's also a provider level and healthcare system level factors that play a role in how outcomes are seen with this population. So I want to turn our attention to how we personalize or how I personalize diabetic therapy in diverse populations. And this is really some of the insight that I've gained in integrating some of the clinical trials and real world data in treating individuals over the past decade and a half. I want to start off by just talking about classifying the level of the disease. And this is really, really important. We have to understand that the majority of people in this country don't come in to see a doctor, particularly an eye doctor, when they don't have problems. Early on, in the early part of diabetes or diabetic eye disease, they may not have any visual problems. They don't come in. But we also know that as the disease level increases, so does the rates of vision loss. And this is where we really see higher rates of individuals that are coming to the clinic if they are Black and Hispanic. They typically come in when the disease is much more progressed. And I think that's really important. Diabetic edema can occur at any stage, but as the disease progresses, so does the increased rates of vision loss. And so screening becomes utmost important. Health literacy becomes utmost important. And reaching those populations to let them know that there's a treatment for diabetes is critically important as well. The current therapies of diabetic retinopathy, I think we're all familiar with. Early on, laser was the first line therapy to treat diabetes. We understood that by adding focal laser to those individuals that have diabetic macular edema, able to decrease moderate vision loss by 50%, and we were able to decrease severe vision loss by 50% if they have proliferative disease. But no one really improved much. It wasn't really into the anti-VEGF age that we really started to see an improvement in vision. And now the anti-VEGFs have really displaced laser as the first line of therapy. There may be a role for laser in patients if they have diabetic edema, but clearly if they have center-involved diabetic edema, the drugs of choice will be intravitreal injections. We know that some individuals may not always respond to anti-VEGF injections. So corticosteroids are important because we know that inflammation plays a strong role in individuals with recalcitrant diabetic edema. And as the disease progresses, unfortunately, some people will require a surgery because of blinding vitreous hemorrhages and tractional retinal detachments. And I think it's really important to understand this because even controlling the factors that patients can control, like their hemoglobin, their blood pressure, their cholesterol, their diet, exercise, and even a decrease in smoking, all these may be insufficient once they develop sight-threatening problems. These things are all important. It's really important for the other systemic things that may happen. But once you develop those significant problems, it really comes down to the aggressive nature in trying to control the disease itself. Here's just a timeline of a historical perspective on the change of the treatment landscape for the treatment of DME. We learned a lot from ranibizumab and aflibercept early on, and they became very effective drugs in decreasing vision loss in individuals by decreasing central macular thickness. It also modifies diabetic retinopathy. Steroids were very important for those individuals that needed um, that may have more chronic problems or didn't really respond as well to anti-VEGF therapy. And really in 2023 and 2025, we've been able to progress in some of our second and third generation treatments. These newer therapies aim to improve longer-acting therapies with extended injection intervals. Some of these medications offered higher doses, where others offered novel delivery systems. Most of these things really play on the vascular endothelial growth factor pathway by blocking VEGF. We know that VEGF is a very potent promoter of angiogenesis, of leaky vessels. And so by blocking these things, you can decrease the inhibition of angiogenesis, stabilize capillaries, and so you can decrease the central retina thickness, which often is involved with center-involved diabetic edema. The problem is that these were mostly every 4 to 8 week injections, and patients need to come in very frequently or at least be monitored even when you extended them. And so there was an injection burden, there was a cost burden, and sometimes patients had a hard time of making a lot of those appointments. So the things that we learned early on in the trials, in the phase 3 trials from Ride and Rise and Vivid and Vista, is that individuals that received anti-VEGF injections, they did fairly well. There was a rapid improvement in visual acuity, and these visual acuities were sustained and maintained over 1 and 2 years. And those in the sham arm, particularly if you look at Ride and Rise, those individuals that crossed over at 2 years and they received the treatment after their 2-year appointment, most of those individuals did not improve significantly in their vision. So this showed that delayed therapy in individuals, you also delay visual rehabilitation just from the chronicity of the disease and probably destroying some of the photoreceptors that helps us to see. We also learned a lot from Protocol I. Now, Protocol I was very instrumental in helping us to design best physician practices. It looked at ranibizumab with prompt or deferred laser versus steroids alone. And what we found is that even at 1 year, nearly 80% of eyes that received aggressive ranibizumab therapy, whether it was prompt or deferred, still required ongoing therapy at 1 year. Even at 2 years, over 50% of eyes still require therapy. So even if they responded, frequent injections still need to be done, and patients had to be monitored closely in order to maximize their efficacy. The early analysis from Protocol I think, was really instrumental and really shaped the way that we thought about the treatment burdens in terms of the number of injections patients need in order to improve in vision. They stratified patients based on after 3 injections, so at week 12. And after 3 injections, they quantified patients in quartiles, whether patients did not do very well or they had moderate or significant visual gains. We found that 40% of eyes did not improve more than 5 letters after 3 injections. And this was quite interesting because we know that if you stress these patients out for a year, those individuals that was in the lowest quartile or did not improve more than 5 letters, they typically had the same visual improvement at 1 and 2 years. And so in each arm, those eyes stay within 5 letters of their response they had at week 12. So typically we see that if patients are not responding by their third injection, we really have to think about switching to a different agent or augmenting their therapy in some type of way. We also learned great information from Protocol T. Protocol T was a trial that helped physicians develop best physician practices when it comes to managing a diabetic macular edema. It was a trial that compared aflibercept 2 milligrams to bevacizumab to ranibizumab. And remember, bevacizumab is used as a off-label use for diabetic eye disease. And these individuals that received these agents typically did fairly well regardless of the medication they received. However, when you look at patients based on their vision, if they were 20/50 or worse, you saw that aflibercept was superior to both bevacizumab and ranibizumab at 1 year, but only found to be superior to bevacizumab at year 1. We further saw a differential response that was evidenced by persistent edema requiring rescue laser at 24 weeks in this a trial, which was pretty aggressive, but individuals were receiving nearly monthly injections. And at week 24, we can see no matter what injection they receive, there was always a need for laser. There was between a 40 to 60% need for laser for those individuals that have persistent swelling. So here you see there's still a differential response in therapy, and not everyone responds to every therapy. Now, when it comes to this at-risk community, we always felt that these individuals did not respond as well. Well, I think a lot of this we have learned from real-world data, and we really didn't have a lot of scientific proof. I think one thing that we see that we've learned from the real-world data is that individuals in the real world typically don't do as well in the randomized clinical trials. Typically, in randomized clinical trials, these individuals typically receive between 8 to 12 injections. In the real world, it's about 6.4 injections. And the mean change from baseline visual acuity in the clinical trials is between 10 and 12 letters, and we typically see 4.2 letters in the real world. So what this shows is that people with DME that receive fewer injections in the real world compared to clinical trials typically don't have the same vision, um, um, final vision, if they receive less injections. So the lessons that I learned from the early clinical trial evidence in diabetic management is that there's a spectrum of response to different DME treatments. There's a differential clinical response that suggests the differences in the retinal microenvironment. The duration of DME may also influence the differential treatment effect, and that frequent injections and with conventional anti-VEGF agents are required to achieve the best visual improvements long term. Now, what about the spectrum of clinical responses? I think that for those individuals that had an incomplete response, which we fairly noted, there was a thought that inflammation may really play a role in this. We know that there was a incomplete response rate of about 40%. These individuals had persistent or chronic diabetic edema. We thought that inflammation may be the driver in these eyes, and that longer duration of therapy may be required. So the thought of using corticosteroids in this population was entertaining, but there was limitations to adding steroids or corticosteroids to these eyes. We were always concerned about cataract formation, cataract progression, as well as ocular hypertension. Now, we do have approved therapies of corticosteroids for the treatment of diabetic macular edema. One is a dexamethasone implant, and the other is the fluocinolone acetonide implant. Both of these use delivery systems to deliver corticosteroids to the back of the eye for a longer-term therapy. Typically, for the dexamethasone implant, it's a biodegradable implant where we typically can see effects up to 3 months. And the fluocinolone acetonide implant, we typically can see results up to 3 years in terms of bioactivity. So in the fluocinolone acetonide implant, although you can measure drug in the eye up to 3 years, is not uncommon that individuals may need supplemental therapy during their course or journey. So I really think it's important that when you use these medications, you explain to the patient that cataracts is a problem. You want to manage their intraocular pressure, but they also may need supplemental therapy if the steroid is not giving you the results that you want. This is a chart that really looks at retinopathy severity scores. And as the retinopathy worsens, you can see that the cytokine levels as the disease worsens all increase, and which is significant. However, VEGF levels does not increase significant as the disease progresses in a diabetic eye disease. We see this differential cytokine response in individuals that have bilateral diabetic edema, where one eye received bevacizumab and the other eye received an intravitreal triacetin injection. And here we can see that the eyes that received bevacizumab, you can see that only the VEGF levels were suppressed. But those eyes that received the intravitreal triamcinolone, you can see that the cytokine inflammatory markers were decreased, as well as VEGF. So steroids did play a role in decreasing VEGF levels, but it was more potent in the cytokine reduction, and maybe therefore more of a pan blockade than what we were seeing with just the anti-VEGF drug alone. So this led to the development of newer pathways, which may be really effective in treating individuals with diabetic eye disease, particularly diabetic macular edema. Faricimab, for example, is the first biologic that has a dual pathway that inhibits both VEGF, which is something we knew about, as well as ANCC2. Well, ANCC2 binds to the type 2 receptor, which is really important for inflammation and stability for blood vessels. And disease eyes, such as diabetes or macular degeneration, or even strokes in the eyes, this type 2 protein, which is really important in the stabilization of retinal blood vessels and also inflammation in abnormal conditions such as diabetes or macular degeneration or strokes in the eyes, this receptor is deactivated by ANCC2, and therefore you have the increased vascular permeability and neovascularization and inflammation that comes along with that. So by blocking this pathway, you may prolong the effects of the VEGF and have decreased injection and may need decreased injections over time. The primary endpoint was the mean change in best corrected visual acuity from baseline. And you can see here from Yosemite and Rhine that faricimab was found not to be inferior to the 2 milligram dose of aflibercept at 1 or 2 years. So the secondary endpoints looking at central retinal thickness in the Yosemite and Rhine show significant reductions in all arms, whether patients receive a Q8-week dosing of faricimab or if they was customized up to 16 weeks compared to the 2 milligram dose of aflibercept given every 8 weeks through year 2. In the Photon phase 2-3 study, we found that the high dose of aflibercept in DME also to be effective. In this trial, aflibercept 8 milligram at every 16 or 12 weeks was compared to aflibercept 2 milligram every 8 weeks following the loading dose. And the goal here was to see if a higher molar dose of an 8 milligram could decrease the number of injections and also achieve very similar vision gains and also reducing a central macular thickness. And we could see that the efficacy in this phase 2-3 study of Photon, that those individuals that were randomized to the Q16-week arm of the high dose of aflibercept and the Q12-week arm did just as good as those individuals that received injections every 8 weeks from the 2 milligram arm and was not found to be inferior. In actuality, 90% of patients stayed on more than 12-week dosing and 80% stayed on Q16-week dosing. So now we had two medications that were able to extend out to 16 weeks by decreasing the number of injections that patients would have and decreasing their burden from coming in so often in your clinic. And again, here you can see that robust decrease in retinal thickness, no matter what medication they had. But again, in the aflibercept 8 milligram arm, you can see that this was done with less injections. The impact of baseline central retinal thickness on visual outcomes in photons are seen here. This is a very interesting sub-analysis where they looked at quartiles of eyes based on central retinal thickness. The fourth quartile, which had the highest central retinal thickness, tend to have a much more rebound effect once the patient were extended 8 weeks after their loading dose. So here you can see in this post-hoc analysis that after the loading dose of the 2 milligram arm, there was a higher rebound of fluid compared to the 8 milligram arm. So disparities in clinical trials, the representation, I think is really important. The reason why this is important is because in all the previous trials, these individuals were underrepresented. And we're always concerned how Blacks and Hispanics would do if they were in these trials. And this is really important to educate patients from these communities so we can give them the information they need. And this is not just specialty ophthalmology. We know that this is a problem across all medicine. We know that in prostate cancer, where there is a 40% mortality rate in Black men, or in breast cancer, where there's a 40% mortality in Black women compared to whites, less than 10% of those individuals are typically involved in clinical trials. And so because of this, we are really interested to see if there's a disparity in the treatment that we give our patients. Now, there was a randomized trial, very small, very short. So I know that that we can't put a lot of stock into this, but there was some patterns that we saw. There was they looked at a retrospective review of individuals that received bevacizumab after 3 injections, and what they found is that after 1 injection, Blacks did not do as well compared to Hispanics and whites, and after 3 injections, the Black patients did worse. They also found out that if you didn't do as well after 1 injection, there was no significant response after your 3rd injection, despite having similar reductions in central retinal thickness. This was the first retrospective review that showed there may be a disparity when it comes to anti-VEGF therapy with individuals receiving anti-VEGF treatment. And this really plays into why we have Elevatum. And Elevatum is a phase 4 trial which looked at faricimab in underserved populations in patients with treatment-naive diabetic edema. This is an open-label study. And what we were trying to do is that we were really focusing on Black or African-American patients, Hispanic and Latino Americans, and also Native Alaskans and Pacific Islanders who are typically not involved or not or underrepresented in clinical trials. One thing that we did is that we wanted to make sure that we weren't excluding people, so we were able to increase the hemoglobin A1C level to 12% for 20% of the population. Historically, for most of our randomized clinical trials, this number is less than 10%, and all patients were treatment naive. And what we found is that overall, patients responded very well to what we saw in Yosemite and Rye. In the Black population, Hispanic population did fairly well from the mean change in baseline central thickness. Now, what I will say is that the baseline characteristics seem to be that Hispanic patients presented with a worsening of visual acuity. They also had higher amounts of central retinal thicknesses and also more advanced disease. And I think this is really important because this next slide here shows the impact on the disease severity, where it shows Hispanics did better than both whites and Blacks when it came to decreasing the level of retinopathy by more than 2%. But again, there may be a ceiling effect on this, or there may be some trends. So this is the second trial that shows that Hispanics actually did better than Blacks. And we're still investigating this trial as we go forward. Pagoda, I thought, was quite interesting as well. And this is another medication that may be very helpful in the at-risk population where the treatment burdens are very high. It was a phase 3 efficacy and safety trial that looked at ranibizumab injections compared to the port delivery system for diabetic macular edema. And what they found is that those individuals that received the port delivery system had similar vision gains compared to those individuals that had monthly ranibizumab injections. The refills were done every 6 months, and it was 95% of patients did not require a supplemental treatment through each of the refill exchange intervals. Equally as important was the data that we saw from Pavilon. Now, Pavilon did not look at people that had diabetic edema, but they were just looking at eyes that had diabetic retinopathy. And it compared those eyes with a poor delivery system at week 36 compared to those eyes that receive monthly ranibizumab injections. And they found superior results in more individuals improving more than a two-step improvement in their diabetic retinopathy score. 80% of individuals in the poor delivery system had more than a two-step improvement compared to 9% in the monthly arm at 1 year. Now, this population was much more diverse than other populations. This was something that was done during the design, where 46% of the Latino patients were in the treatment arm and 42% was in the control arm. There was 13.2% of Blacks in the treatment arm compared to 5.9% in the control arms. And this historically is much higher than we had in prior trials. Over 75% of patients that receive the poor delivery system prefer to have the delivery system over having monthly injections. Now, this next section, I really want to focus on recognizing diversity in patient care and how do we identify strategies that may improve a diabetic retinopathy treatment. I think this is really important. I think this is the most important part of the talk. Understanding the patient journey and understanding how the patient comes to your office. When a patient comes to our office, most times it's coming from an optometrist or a general ophthalmologist. I think those individuals are great because they are your first line of defense. Oftentimes, patients are aware that they have some problems in their eyes. Most time they are aware that it's diabetic related. They may have even had a conversation about how diabetes affects the eyes or just some information about diabetic eye disease. But then there are some people that come from the physician assistant, nurse practitioners, their PCP, or even their endocrinologist. This may be the first time they're coming in for an eye exam. They've never seen an optometrist. They're coming into you directly, or they could come to you by way of the optometrist. And so how the patient gets to you, I think, is critically important. And I really think that when I retrospectively, if I look at my patients, those individuals that typically come from the endocrinologist, most times they have vision complaints. They have complaints that the eyes are blurry. They have floaters. And so I know the disease oftentimes have always more progressed. Sometimes they're coming in from the endocrinologist, and this may be the first time they've seen you just for a baseline diabetic eye exam. And so they may not have any problems at all. But understanding how a patient gets to you is critical. I think during that appointment, it's very critical for you to establish the importance of routine exams. If they have no problems at all, explain the importance of what you do in terms of their diabetic care, making sure they don't have problems. If they do develop problems, early diagnosis leads to early treatment, leads to better outcomes. If they do have diabetic eye disease, I think staging the diabetes is critically important, making sure that they don't have any sight-threatening problems. Joslin Clinic did a great paper, and 50% of patients that were coming to the clinic had sight-threatening problems, and the patient was not aware. So oftentimes, patient may not even be aware when their vision is fairly good. And we know that those individuals that come in with more severe non-proliferative disease, we know that 50% of these individuals may develop sight-threatening problems over the next 3 to 5 years. So following these patients closely, I think, is critical. The most important thing that we have in our office is really the power of photography. Other clinics may not have sort of things where we can show individuals what I like to say, a key into their soul. Look at their eyes, look at the hemorrhages, the bleeding, the exudates, do the fluorescein angiograms. I typically use words like dying tissue to describe ischemia. I want them to know that this is a serious problem, and I want them to make sure that they keep their follow-ups. It was really important to mitigate their anxiety, to explain their what their treatment may be like during this exam. Oftentimes, they think that they need one injection, then they may be done. This is a good time to lay that framework down, break down those barriers, be your authentic self, and have a great discussion. It's also a great time to understand the importance of cultural sensitivity. how individuals may want to be addressed. In my clinic today, I see a lot of individuals that don't look like me. They may look like me, but may not dress like me. There's a lot of things. We have a lot of transgender individuals that come through our clinic, LGBT community individuals that come. You want to make sure you're addressing these individuals the right way to make sure that they are feeling comfortable. You want to help them understand that they may need frequent injections. I think that's the most important thing. Patients always want to know, well, doc, how many injections do I need? Some of them may be aware they need treatments. And so I typically tell them that first 6 months to a year is critical. I'll let them know that first 3 months, if we're not getting the response I want, we may consider switching them to a different agent. We may have to add supplemental laser. So I add some of these to our discussion. A lot of times in that first appointment, I may never even inject the patient. That could just be time that we're talking about care because they're already coming in, they're very nervous. So giving someone an injection the first time they see you, I think sometimes can be very difficult. But the most important thing, you want to make sure that all their questions are answered. You want to make sure that you have their undivided attention, you're your authentic self, and you lay down the guidelines of your expectations of what you expect their therapy to be um, during the course of their journey. Some of the things that can really help us with the increase, particularly when it comes to screening, is really telehealth. A lot of individuals don't live close to us. We know that when those clinics are far away, those individuals are just not coming to the clinic. So how can we leverage the telehealth technology that we have with AI to get those patients early? We know that 50% of individuals that are coming to see us, where can we meet them where they are? So using this type of technology where individuals can look at those photographs and get those high-risk patients in quicker, I think is critically important. One study found that you can increase screening annual rates from 26% to 40% in one study, and the other was 50 to 75%. These are phenomenal. These are phenomenal numbers, and it could be a big turnaround for a lot of patients. It's very cost effective, particularly if you're identifying those individuals that have high risk disease that have not lost any vision. What we don't want to do is see those patients in the emergency department. Unfortunately, this population oftentimes may not have a primary care provider. They may not have an endocrinologist. They may not have any physicians that they're seeing, or may go to a free clinic to receive their diabetic medication. Or oftentimes, when they present to the emergency department, they'll have things like floaters, which may be indicative of a vitreous hemorrhage or tractional retinal detachment. And by the time they're referred to you that following week, you look in the eye, they have very severe advanced disease. The system failed that patient. We did not get that patient in soon enough. Comprehensive dilated exams should be performed on all these patients. If someone is seen in the emergency department, we want to make sure that those individuals are fast tracked to your offices. I don't mind receiving those calls from the emergency room. If you're in a tertiary center, oftentimes they would have an ophthalmologist on call. And oftentimes, if it's not a retina person, they will refer you to your office. But the emergency department need to have a way to facilitate that patient in seeing you and be able to be fast tracked without going through a lot of red tape. Now, when you look at barriers, it's really multi-level. And I think that all these things are important when it comes to addressing disparities. When it comes to clinical trials, which is really near and dear to me, I really think it's important that we understand the community. If you're a person that is trying to develop a clinical trial site, you have to understand what the needs of that area requires. It's really good to do an assessment. If you're a service in an area with high diabetes and you want to have a diabetic study, you want to be able to put those protocols together where you can include those patients to be more inclusive. And that's where you're inclusive and where your inclusion and exclusion criteria may be really important. The hardest thing is finding the infrastructure. To develop infrastructure, you would need the man force, you would need the space, you would need study coordinators. Oftentimes, they will have to be trained on different protocols, and so this may be a cost to the practice. So, selecting the right trial based on your geographic location, I think, is critical. You will be you will be delivering a care to a community that really has not had the ability to participate in clinical trials. Um, when it comes to the individual level, I think it's really important for them to be aware of trials. I think for us, a big thing that has been really helpful with social media, putting things on your website, if you do different talks or different trials that you um, are recruiting in, you put those on your website. So when patients are looking at your website, they can go to those trials and be more aware of things that you offer. I really do think that this uh, is a significant buy-in with the community. If the community think that you really have their back, I think it's really easy to get them involved in trials. The hardest thing about getting people involved in trials when it comes to diabetic eye disease is that oftentimes the first time you see the patient is the time you need to be thinking about a trial. You need to find a way to bridge clinical trial discussion along with clinical discussion. So when I see that patient for the first time, I'm letting the patient know what they have and what my expectations shall be, but I also let them know that there's an alternative to the recommended treatment that we just talked about. And I talk about the pros and the cons of our current therapy. I talked about the burdens of our therapy. I talk about not everyone responding the same to all treatments. The same thing we talked about before. And I let them know the goals of the trial. Oftentimes, we're looking for longer biologics, less injections. That really resonates well with individuals. I also talk about the wait times in the office. Oftentimes, it's not uncommon for me to be an hour and a half or 2 hours behind the clinic because I'm seeing 80 to 100 patients in a day. They have to understand that if they're in a clinical trial, there's someone responsible for them. There's a clinical trial coordinator that they can call at any time, and they have direct access to me. When they come see me, they are waiting for them. When they come in the office, they see the exact same clinical trial team for their evaluations, for their dilations, etc. It's a team that's centered around them. So they are a VIP person. All the T's are crossed, all the I's are dotted, and we'll make sure at the end of the trial, our job is also to make sure that they're whole and that they don't have any out of pocket expenses. So these are, I think, high touch areas that you can leverage in your own space, or if you are interested in developing trials in the at-risk population. I think all these things resonate fairly well. I think it's really important to advocate inclusivity in trial research. It's really important to work with community members. We do a lot of work in the community. I think that when it comes to Northeast Ohio, we have a very diverse population. A lot of these individuals will take more stock in what their pastors tell them or what their rabbis tell them. And so doing community outreach programs in different churches or different outlets are critical. Being present where patients are, I think is important. When I came to Cleveland, we had one trial site. Our trial site was located in Beechwood. If you know Beechwood, it's one of the most respected Jewish communities in the area. And I don't think we recruited very well in diabetes. We did very well in other trials like AMD, but not well for diabetes. So what we did over the years is that we were able to put trial sites on the far east side and the far west side where those underrepresented patients are. And that really boosted the recruitment. It's also really important to be present in those communities. And it's also good to give feedback. Once you have a trial, it's also good to let the community know what the results of those trials were. Um, when it comes to recruitment, I think it's also important to have flexible hours. We are probably one of the few individuals that have Saturday office hours. I know that may not be appealing to some, but just being able to assess patients when they have emergencies on the weekends and after hours, I think is really important just to make sure that they know that they're taken care of if there is a problem. And the most important thing, again, is providing education. I always give information to all my patients when they come in, and particularly it's really important to have information in people's native language. And for the most of us, it's going to be Spanish. We do have Spanish speaking interpreters at my institution. And when they're not there, we have the ability to use virtual Spanish individuals that will talk through a screen to help me mitigate the manpower that I may not have that day. And again, remember, the most important reason why people are interested in trials is because you, the physician, asked them to be part of a trial. So it's really important not to make assumptions who may or may not participate. I think it's really important to deal with your own implicit bias and be inclusive when you are talking about clinical trials. Resources, I think, are also really, really important. On our website, we have a number of resources that patients can go to for more information, even information about injections. We give patients information about their injections, what to expect. We offer them a courtesy call within 5 days to make sure that they're doing okay. We can always continue that call if need be, or they're always welcome to call with any problems. I really want to end with the story of Janice. And Janice is a 63-year-old Black woman who is coming to see a retina specialist for the first time. She's been told by her endocrinologist that she's to follow up with the physician, but for some reason she never did. She mentions that her schedule is very tough. She does take care of her grandkids, so she does have some travel restrictions, and she's just very nervous about having her eyes poked and prodded, and really was nervous about the exam when she came in that day. On that day, she told us that she had diabetes for over 12 years. She does the best she can, but her A1C is 9.5%. And that was actually better than when she was first diagnosed at 13%. She's also on medications for high blood pressure. She has coronary artery disease, has 2 stents placed, and she also has some kidney problems. She really noticed some changes in her vision while driving, and she really knew that she needed an eye exam. Well, when she came in that day, her visual acuity was 20/70. She did have an eye exam 3 years ago. At that time, she told everything was fine, and she lives about 45 minutes away from the clinic. Now, when you look at this, I think it's really important from a physician standpoint, or even from your technician standpoint, to really understand this patient journey. You understand that, she hasn't had the best eye care because she should have been seen multiple times over the course of 12 years. She has comorbid problems. She has cardiovascular disease. She's already has kidney disease. Most likely, she may have eye problems given the fact that she can't see. And her biggest thing is she lives 45 minutes away from your clinic. And so with the visual acuity of 20/70, most likely she's probably not driving, or if she is driving, she should not be driving. So she's going to rely for someone to bring you to the clinic, particularly this long way, that may not have the support system to bring her in, to bring you in when she needs to be seen. On presentation, here's her eyes. You can see that she has moderate to severe diabetic retinopathy, at least based on this fundus photograph sitting on the macula. There's a fair amount of hard exudation, which means that she probably has some chronic swelling going on. And they're center involved diabetic edema, which is the reason why she probably can't see. On this day, we try to leverage things we had in the clinic. We gave her a lot of information, and we spent a lot of time trying to decrease her anxiety and let her know what she needs. I did think that she was going to be a high touch person, let her know that she need to come in almost on a monthly basis. And I was hoping that over the course of 6 months to a year, that I'll be able to decrease those injections once we see the improvement in her vision. And I want to say this is probably the most impactful thing that we can do when patients are coming to our clinic. Show them a key into their soul, I call it. Look at their eyes. This is the first time they're able to see an organ that they have problems, and use the bad terms, abnormal blood vessels, show them the bleeding, and use the words that they may feel a little uncomfortable with. But the rainbow is that most times patients do a little bit better. And so I think that's the part you want to give them. And once you start therapy, I think it's also really critical to share in their wins. 6 months or a year later, here she's at a year later, you show them the photographs and you show them the improvements. You show them that the hemorrhages have gone away. You show them that the exudates are decreasing. You show them that the OCTs are getting less, and you show them the visual trends, particularly if they have significant visual gains. This is how you buy equity with these individuals. We typically think that individuals from these communities don't follow up because they're non-compliant. Well, you know what? Real life happens. They're not just seeing you. We know when they have diabetic edema, they have more trips to the ER and to their physician than those individuals that don't have DME, and they just miss their appointment because life happened. They had an acute episode of congestive heart failure. They have pulmonary edema. something changed in their life. And so it's really important to understand their journey, meet the patient where they are, and make sure you try to deliver the best care that you can. So this brings us to the end of our discussion and a close today. I hope that you found this activity informative and useful to your practice, and I encourage you to access the supplemental program materials. And I want to thank everyone for tuning in and participating in today's discussion.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Genentech, a member of the Roche Group. To access all materials for this activity, visit peerview.com/SYS860.